Welcome to the Medical Report. Our discussion today is going to be surgery of the shoulder. And to discuss this with us today is Dr. Adrienne Towsen. Dr. Towsen is a board-certified orthopedic surgeon with a fellowship training in sports medicine, and she is associated with the Chester County Orthopedic Group. So we appreciate your coming and spending some time with us. We'd like to learn a little bit more about shoulder pathology and the injuries that happen. We have a group of athletes here, you know, in Hershey's Mill. So I'm sure they'll all want to know a little bit about, first of all, the anatomy of the shoulder and what things can happen.
Great. Well, I'd love to be able to explain that. I do have a model with me here today that we can use a little bit, but the most important group of muscles in the shoulder is referred to as the rotator cuff. And many people have heard of the rotator cuff, perhaps injured the rotator cuff, and it's an important group of muscles in the shoulder. In this model, if we could take just a brief look, the humerus or the arm bone is right here. The shoulder blade is on top. The socket is sort of buried down deep inside. The rotator cuff is represented by this area here, this soft tissue muscle, and it's not clearly defined in this model, but the muscle is attached to the bone by a tendon. The rotator cuff is actually a group of 4 muscles, and those muscles function together to position the arm in space, to raise the arm up overhead, out to the side, reach behind your back. So I often refer to it as the workhorse of the shoulder. It's really an important group of muscles, and therefore it's very susceptible to injury, both overuse injuries and traumatic injuries.
Now what our audience is looking at here is the front part of the shoulder, and that's the clavicle going off to one side. Perhaps you could rotate it around to show them the rear aspect.
Certainly. Yeah. So here's the posterior back view of the shoulder. The large bone here is the scapula or the shoulder blade, which has many irregular prominences that are muscle attachments. And as Dr. McCabe pointed out, the clavicle or collarbone is right here. And then the collarbone makes a joint with the shoulder blade, which is up top here, and that is often an arthritic area for many people. The actual shoulder joint is deeper down inside, and if I can pull the humerus or the arm bone away a little bit, the socket is down deeper inside, which is called the glenoid, and that's the shoulder joint itself.
So this shoulder has a little ball on it that rotates in that socket, is that right? It
does. It's very much like a hip joint in that it is a ball and socket joint.
Now, what are some of the most common disorders that can occur with the shoulder, particularly in our age group here that you're talking with?
The most common thing that we will see by far is a rotator cuff problem of some sort. And there's a wide spectrum of rotator cuff pathology or problems, including just a tendinitis, which would be an inflammation and overuse of the tendon. Often that is accompanied by a bursitis, which is an inflammatory response in some tissue that sits above the tendon in this space. And then very commonly we are actually dealing with rotator cuff tears as well. And what that means is that the tendon attachment, where the muscle attaches to the bone, actually tears away from the bone, and there are variations of that. Certainly we also see arthritis, as I mentioned earlier, in the joint between the collarbone and the shoulder blade, also sometimes deeper down into the shoulder joint, but without question, by far the most common thing that I'm treating on a daily basis in many age groups in the shoulder would be rotator cuff pathology of some sort.
So in this age group here, though, it's not unique to older people, though. It can be in the younger age group as well.
That is correct.
Yeah, okay. Now, what is the overall incidence of some shoulder pathology, would you say, in the general population? I realizing there's certain subsets, but...
Right.
Yeah.
It's actually quite high and quite poorly defined, because many of the problems that we deal with routinely, including the rotator cuff, present in such different ways, and many people can not be particularly symptomatic from a chronic rotator cuff problem. So it's documented in our literature anywhere from 5 to even 40% of the general population across age groups could be dealing with a full thickness or complete rotator cuff tear. And then other issues, including the tendinitis that I mentioned, and more overuse injuries, maybe less severe injuries, can be an even higher percentage than that in the general population. So really in a lot of the different places you read, it's poorly defined. It will often say the incidence is unknown because there is such a wide variation of problems considered rotator cuff issues, and it's basically what I would tell you is it's incredibly common. It is it fills our office every day, anywhere from tendinitis to tears.
Now, what are some of the causes of these different disorders that you've discussed? Tendinitis, bursitis, rotator cuff tear, and so forth.
Well, very often with tendinitis and bursitis, it is more of an overuse problem where just sometimes with routine daily activities, people can develop these issues. Sometimes with sports or recreational type activities that might be a little above what your everyday activity is, or even exercise that you're doing maybe with some light weightlifting or things that involve repetitive motions with the shoulder can cause a tendinitis or a bursitis. We will sometimes see tears caused by more traumatic events. People can have falls or lift something, go to lift something heavy and it falls, and that may cause an actual tear in the tendon. And lastly, just degeneration of the tendon over time, which is very, very common as we get into the 5th and 6th and 7th decades. It's more of a wear and tear phenomenon just with aging that can cause either a tendon to partially tear or completely tear without a traumatic injury.
Now, we have a lot of people in this community who play tennis and also play a lot of golf.
Yes.
These are the two major sports. I don't think there's any football players or baseball players still active, but is there anything about either of those activities that people should be very careful about?
Both of those activities certainly do put stress on the shoulder, and I will find many golfers and tennis players commonly with rotator cuff issues, including what we've discussed already, the tendinitis, and occasionally a tear even from that type of activity. Golfers often can accommodate for a rotator cuff problem pretty well. Sometimes it will depend on which side it is, which arm it is, but it's more the repetitive nature than anything else of these sports, just like other more routine activities that cause wear and tear over time. Certainly an overhead serve and some of the other more aggressive tennis serves or moves would potentially cause a problem with the rotator cuff, and really it just comes down to the repetitive nature of it. So one thing with tennis, for example, we'll say if you can, play doubles or do something that might, lessen your need to be hitting quite as often, that's one way to accommodate it if you're having a problem with the rotator cuff.
That's very good. Now, doing the dishes every night's not going to do it, right?
No.
Okay. We have, certainly, there's got to be some diagnostic clues that tell you just exactly what's happening. Could you tell us a little bit about some of the symptoms that people would experience?
Absolutely. The most common symptom that people will present with in the office is pain. There is generalized pain around the shoulder, but more often than not, the pain is actually down into the upper arm. And very commonly, people will be surprised to know that the pain in their arm is actually related to a problem that's deeper in their shoulder. So pain is a common presenting symptom, again, often in the arm. People will have pain at night, which is very common. Sometimes people are able to get through some daily activities reasonably well, but when they lay down in bed, particularly if they like to sleep on that side, it can be very difficult. And there are certain very characteristic limitations with range of motion, particularly raising the arm up overhead, reaching out to the side. Rotational motion, such as reaching behind you to pull up a pair of slacks or get something out of the back seat of the car, things like that will be very difficult for people, either with with a tendinitis or with a tear. So there are limitations with range of motion. There's pain. very commonly night pain, and people will have varying degrees of weakness. There will be limitations with the ability to do overhead activities often and do anything that requires any type of a heavy lifting or sustained position overhead.
So sometimes the pain then will radiate right down the arm.
Absolutely, it can. And I have some patients where it will radiate down beyond the elbow. It's very common, and really across the board we see it in the upper arm. That's always there. And sometimes symptoms will come even further down the arm into the hand.
So when you do a physical examination of someone with one of these things, are you looking for areas of local tenderness or restriction of motion, or what are you looking for when you do the examination?
Mm-hmm. There can be areas of local tenderness up around the shoulder itself, near this area here and part of the shoulder blade, where sometimes people will have a bone spur that might cause some impingement on that tendon and may have contributed to the tendonitis or the tear. But more importantly with the physical exam, we're looking for limitations in range of motion, looking for certain positions that we can put the shoulder in that will elicit pain that are characteristic of a rotator cuff tear. For example, raising the arm completely up overhead or rotating it in certain positions will cause contact between these two bones here, the humerus and the part of the shoulder blade, and that will cause pain. So we have certain provocative tests that are very telling. And one of the biggest ways, or one of the easiest ways to clinically try to determine whether the tendon might be torn or not is by weakness. There are a couple of positions that we can put the arm in that really isolate the rotator cuff, and if people are weak just to physical testing, just to my resistance, it can be a very telling sign about the possibility of a tear.
Yeah. So that the diagnosis that distinguishes a tear from simple inflammation of an area or by different maneuvers that you will do to demonstrate that. Is that right?
Yes.
That's oftentimes confused. And so
Yes.
that was the reason I asked that question. Now, if you're in your mind not certain, what diagnostic studies would you perform to help you with the diagnosis?
The absolute best study to diagnose a rotator cuff tear or any variation of rotator cuff pathology is an MRI scan. We can get all the information that we need generally from an MRI because it's a great study to look at soft tissues. We can do simple x-rays and that will certainly show the bones and the joint relationships, and they can be helpful, but in order to fully image the rotator cuff and be able to tell for sure whether it's torn or not, or whether it's inflamed, and then exactly the degree of the tear, because there are small tears, medium-sized tears, large tears, and so on and so forth. An MRI scan is the best study, absolutely.
And that shows you if a muscle is actually torn off. You can actually see that on the MRI.
Yeah, absolutely, yes.
Whereas you can't do that with a standard X-ray.
That's true.
Which is a big distinction. And so people will often say, I had my shoulder X-rayed, didn't see anything.
Right, correct.
That's good. Now, I think one of the things we like to kind of summarize what we've talked about here is you have a category of injuries to the shoulder, the most common of which you see is the rotator cuff tear. Is that correct?
Yes, correct.
And so we're going to wind up this particular session with letting Dr. Towsen kind of go on a freelance here about what people come in to see her about and what is the most common thing that people do to cause it, and what are the most frequent complaints. Could you do that for us?
Yes, sure, absolutely. In taking care of primarily shoulder injuries for the past 4 to 5 years, again, the most common thing I see in the office are people with injuries to their rotator cuff. I saw about 20 patients in my office this morning, and 15 of them were rotator cuff problems. It is really a very, I consider it an epidemic sometimes because it really is just the most common thing that I see. There are other tendons in the shoulder that can become inflamed. For example, the biceps tendon, which this model unfortunately doesn't show you very well. It travels down the front of the shoulder into where the bicep muscle would be here in the front of the upper arm. And it actually lays right under the rotator cuff tendon, and it's pretty common for people to have associated biceps tendonitis if they have a rotator cuff problem, or they might have an isolated issue with the bicep. It's possible to rupture or tear that tendon as well, but typically that's far less symptomatic, and we often don't really have to do anything for that, but it's an injury that we often, or that we will see as well. It is not as common, but I certainly do see a fair amount of shoulder arthritis in the office. And I'm talking, when I say shoulder joint arthritis, that's the deeper joint, the shoulder joint itself, deeper down inside this model. And unlike the hip and knee, which we certainly treat a lot of arthritic conditions there, many people can tolerate a good bit of shoulder arthritis before they become very symptomatic from it. So even though we can do joint replacement for the shoulder, and it's very successful just like with the knee, it's often not as necessary. Far more common to need to do something to fix a rotator cuff tendon.
Well, that's a very interesting discussion, and please stay with us because we're going to talk in the next session a little bit about the therapy. So stay tuned. Welcome back to the medical report. For those of you who are just tuned in, we have today Dr. Adrian Towsen, who is an orthopedic surgeon from Chester County Orthopedics with a fellowship in sports medicine, or sports medicine and orthopedics. So we have just discussed a little bit about the disorders that can occur in the shoulder, and we're going to discuss on this session how to treat some of these things. So we're going to start with the more simple methods and simply the oral medications and things, anti-inflammatories and so forth that you would use initially.
Okay, so the treatment algorithm for rotator cuff problems and some of the other issues we commonly treat in the shoulder is pretty similar. And as Dr. McCabe mentioned, one of the first steps often and one of the easiest things to do is to try an oral medication. And since many of the issues we're treating involve inflammation as part of the problem, whether that's tendinitis or whether there might actually be a torn tendon, there's often associated inflammation with that. So one goal is to try to decrease the inflammation, and there's a whole host of anti-inflammatory medicines, including things available over the counter, such as your simple Advil, Aleve, things that you have at home, I'm sure, and pick up at the store easily. As well as prescription versions of the anti-inflammatories, which are typically just stronger doses such that you can take a fewer number of pills and get a little bit stronger dose and a little better effect of the medicine to treat inflammation. And so our goal with the medication is to decrease inflammation, which should thereby decrease pain as well. We can use other types of medicines that are more directed just as pain, that are truly pain medicines and not anti-inflammatories, and there's a role for that at times, but our goal is to try to use as simple as possible a medication and something that will not be harmful. Unfortunately, the anti-inflammatories for many people are a little tough to take sometimes due to some stomach upset. And that's one of the most common side effects in the short term, so we are very sensitive to that and sometimes can't use those medicines as much as we might like to.
And could you make the distinction between analgesia and anti-inflammatory? Some people mix that up.
Absolutely. Yeah, the goal behind an anti-inflammatory medicine is to do just that, is to shrink down inflammatory tissue, which is, if it's a tendon or a bursa, tissue that gets bigger, gets swollen, and we want to shrink that down. If that is the primary irritant, if that's really the problem, then by getting rid of that, we can also get rid of pain. However, if inflammation is not necessarily the cause of the pain, there are times where a true pain medicine that's not really working on inflammation, that's more of a narcotic pain medicine, is appropriate because the issue is not related to inflammation.
Yeah, that's good. Now, when you start somebody off on an oral medication, an anti-inflammatory, what is your rule of thumb as to the duration of time you're going to allow that to go on until you decide to do something else?
A lot of times we'll use that right off the bat in conjunction with another treatment, but if we're starting just with a medication, I would often like to give it at least 10 days, if not 2 weeks, or sometimes as long as 4 weeks to really see if it's going to be effective. Many people will take anti-inflammatories here and there and not on a regular basis, and they can certainly work in that manner, but in order to truly get to a level in the bloodstream where it's being very effective as an anti-inflammatory, we will typically keep people on that for at least, like I said, at least 10 or maybe 14 days as a reasonable trial.
So you're looking for a sustained blood level rather
Yes.
than people will forget the medicine and wonder why it doesn't work.
Correct.
And they get one dose and it's gone. So you're looking for a sustained blood level over a period of time.
Yes.
Now, given failure of the oral medicines that you've talked about, what would be your next step?
Often we are able to do the same type of thing, meaning fight inflammation by using injectable medications, and some people are very much helped by a cortisone injection. Most people have heard of cortisone, which is a steroid medication, and a steroid is also an anti-inflammatory, but it's a stronger version of that type of medication. The oral medications we just spoke about were non-steroidal. There are also oral steroid medicines that can be taken, but they have more significant side effects, so we definitely try to stay away from those if we can. The injectable steroids are nice. Many people are very familiar with the cortisone injection. Many patients I see in the office for a first-time shoulder visit might have had cortisone for another problem. And again, it's an injectable steroid. It's an injectable anti-inflammatory that you'll put right in that spot, right in the location, you know, for our purposes today, right around that rotator cuff issue in the shoulder there. And it works locally to decrease inflammation, so having the same effect that we talked about with the medication. It's a local injection, so it's not systemically absorbed. There are typically no significant side effects other than sometimes people get a little bit more painful for a day or so, when we call that a flare reaction, but that doesn't happen to everyone, and if that happens, it's temporary, and then the effect of the medicine is usually pretty quick acting after that.
Now, we've just discussed a little bit about anti-inflammatories for injuries that are inflammation. Now, when we get into the point where there's some kind of a repair required, and we're getting into the surgical aspect,
Yes.
Let's talk a little bit about what you do from a surgical perspective.
For a surgical treatment for a rotator cuff tear, and it's probably best to just focus on rotator cuff tears because more often than not, the tendonitis and the bursitis issue, if not associated with a tear, can be treated without surgery. We can typically get that under control with either a medication, an injection, possibly some physical therapy. But when there is a tear, the tendon really has no ability to heal itself. So often if people have limitations, whether it be pain, weakness, lack of range of motion, or all of the above that are not being treated well enough with those other types of things, surgery becomes a very reasonable option. The surgery for rotator cuff repair has evolved a lot over the past 10 years or so, and now is really, by and large, an arthroscopic procedure. I have not done an open through a regular sort of big incision, if you will, rotator cuff repair in about 6 years. So I think there's certainly a role for it still, and some surgeons prefer to do it that way, but people who are trained to do the arthroscopic techniques can handle even the biggest tear arthroscopically, which makes it less invasive for the patient and usually makes the early part of the recovery a little bit easier.
Could you describe that instrument a little bit for our viewers?
Yeah, absolutely. Arthroscopic surgery is the minimally invasive technique, and we use an arthroscope, which is a small little instrument, a skinny little instrument, almost like this device I have right here. This is actually an anchor, and we can talk about that in a minute, but the arthroscope is very skinny, and it has a little camera that sits on the end, and then we're actually able to insert that into the joint in this manner, more or less, and allows us to visualize the entire joint. And then while I'm doing the surgery, I have instruments in the joint, but I'm actually watching a TV screen across, not fully across the room, but on the other side of the table from where I'm working, and doing the surgery by viewing things on the TV screen. Then through just very tiny little incisions around the shoulder, it usually takes a few different incisions placed around the shoulder, we're able to use special arthroscopic instruments to get the same work done that we used to do through an open incision through some very small incisions by watching what we're doing on the screen.
And what can you get through this little cannula that you have here?
What I'm showing you is actually an anchor, and we use what are called anchors to repair the tendon. It's like a little screw that goes into the bone, and then there's stitches that we use to tie the tendon back down to the bone, because basically you would imagine that this edge here is lifted off of the bone and we need to reattach it. We do work through little hollow tubes, which are called cannulas, and we can put an instrument, again, something about the size of this, or thinking of maybe like a pen. Instruments are about that big, and we can put them through the cannulas, and we have different instruments that are aimed at performing different functions in order to get the repair done.
Well, this certainly is and how long does it take to do most of your procedures?
A standard arthroscopic rotator cuff for me takes about an hour to an hour and a half. So it is a relatively short time, and therefore a relatively short time under anesthesia, which is good. And then it is done as an outpatient, so our patients are able to go home the same day. It works out very nicely that way. The recovery period beyond that, including the physical therapy and the rehab, is not very different than what it was 10 years ago, and not any different whether it's done arthroscopically or open. But the minimally invasive nature of the arthroscopic procedure certainly causes less pain in the early days and weeks after surgery, and less disruption of the other muscles around the shoulder that we would typically have to dissect through to do an open surgery.
And what are your expected outcomes on these procedures?
We do get very nice recovery and results by and large. There is as high as a 30% incidence listed out in the literature of recurrence of rotator cuff tears even after surgical repair. And that might be a repair that never quite healed, or possibly a re-tear. And there's a lot of gray area with that as well. But what I would say is there are a few factors that come into play that determine the outcome by and large. One would be the chronicity of the problem. We do see many people who have had long-standing issues with their rotator cuff and may have even had a tear for a long time and didn't really know it because they compensated well for it. But what that leads to is tissue degeneration, muscle atrophy, and sometimes tissue retraction, such that the tendon edge moves, if it belongs here, it moves way over here and is very hard to surgically get it back to here. So when the tendon retracts and the tissue is not as healthy as it once was, it can be hard to repair. Sometimes bone quality is an issue, particularly in the older population. If people are dealing with osteoporosis, when we need to insert anchors into the bone to reattach the tendon, sometimes the anchors don't hold well in the bone. So bone quality, tissue quality, muscle atrophy, those are all factors that come into play, and there are times where I can leave the operating room and know that the repair is great, is perfect, everything was the way it should be, the tissue was great, the bone quality was great, and there are certainly other times where I can say, well, we got a reasonable repair, but tissue quality wasn't as good as I had hoped for, the bone quality was not as good, and sometimes, the expectations are a little bit lower in that setting. And physical therapy following it is very important as well, and there's a protocol that we follow, and if people don't stick to that protocol, there can certainly be some issues as well.
That was going to be actually my next question. I think some people don't pay much attention to that suggestion that you would make in rehabilitation. And what would be an ideal setting? Should they go to a physical therapist, or will you give them exercises? How do you do that?
For rotator cuff repair, we have a very specific protocol, and I think it's absolutely essential that a physical therapist be involved, and someone actually goes to formal physical therapy. At least, often it's for a couple of months at least, and then because we go through certain phases, first working on range of motion and then working on strengthening, but it's very important because early on a lot of the work needs to be done by the therapist as far as hands-on stretching, and then a lot of guidance is necessary as you proceed through the protocol. Once you're in the final phase, which is strengthening, many people are fine to do a lot of that on their own. Some people freely admit to me that the structure and the guidance of therapy and actually having to go somewhere and be responsible to someone makes it easier. But some people are very dedicated to do that on their own as well.
So when these folks start therapies, do they have pain?
Absolutely.
Yeah.
There is some. It varies. It does vary, but it's usually the first few weeks can be sore, and therapy days are typically, you know, more sore, and people need some pain medicine to help with that.
Yeah. Okay. Well, I think this has been very, very interesting. And do you have any other comments about this process from beginning to end? Do you have any observations you've made over the years?
Well, sure. The biggest thing I would say is that many people are scared of surgery of any type, which is understandable. Even the arthroscopic surgery can be a bit scary. But, and then the thought of needing to be in therapy and recover for several months following surgery often will turn people away from it. What I would say is if you are limited by pain, lack of range of motion, weakness from a rotator cuff tear, and nothing else is helping, it's really worthwhile to consider the surgery, because people do gain much function back, and as they go through the rehab, they find that it's really, most often what I hear is that, you know, it wasn't as bad as I thought it was going to be. And I hear that enough times, and believe me, I have over the past several years, that I try to reassure patients both ahead of time and along the way that it's going to be worth it.
So, all in all, now, don't be afraid of surgery, so if you need it. And that's a very, very important point, and that's one of the reasons I brought up the physical therapy part of it. We thank you so much for joining us today, and I'm sure our viewers know a lot more about the shoulder than they did before we started, and we hope you enjoyed it. Stay tuned.
My pleasure.
And stay tuned to stay informed.